This is the Mechanical Care Forum, episode 399. It's season 13, and we're highlighting the Mckenzie Institute International's Diploma program. We're reconnecting with one of my fellow candidates and our clinical instructor, this time in Austin, Texas, with Emily Dabrowski and Chris Chase, for more discussion on the clinical placement, 360 hours of practical clinical work and mentoring, this week on MCF. Hey everyone, welcome back. Thanks for joining us today as we continue to explore the Mckenzie Institute International's Diploma program this season, season 13 of the podcast. This episode is brought to you by the Mckenzie Institute International. The Mckenzie method of mechanical diagnosis and therapy is globally recognized as a leading treatment for back, neck, and extremity disorders. Personally, MDT has made the single greatest positive influence on my practice, hands down. The Mckenzie Institute International offers this diploma program to those professionals who've achieved prior certification in the method. It's the pinnacle of MDT training. Successfully completing the diploma program will place you amongst the world's elite in mechanical diagnosis and therapy. If you're interested in learning more, here are a couple of ways. First, stay tuned to today and be sure to follow us all along through this season, season 13, as we highlight this year's cohort of students through the program and get perspectives from the CEO of the Mckenzie Institute International, this year's candidates, as we hear from some of the instructors and more. And second, be sure to go to the website to learn more about the program and how to apply. You'll find that by going to mckenzieinstitute.org and clicking on the Education tab and scrolling down to International Diploma. So this season, we've already introduced you to this 2023 cohort of diploma candidates. We've spoken to those who lead and direct this program, some recent graduates to hear their perspective, some of the clinical instructors of the theoretical portion. We've also spoken to this year's cohort of candidates as they go through the program, mid-theoretical and post-theoretical, and those who provided instruction on the theoretical portion as well. We've gotten updates from my classmates as they've accomplished that first theoretical portion and gone into the clinical placement. In today's episode 399, we'll catch up with Emily not too long after I completed the phase, and as Emily was about in her 7th of the 9 weeks of the clinical placement. She and I and Chris Chase, a longtime clinical tutor, will share about the clinic, the structure of the 9 weeks, the plan for candidates through this phase, how it's individualized for each clinician, some of our struggles and revelations, and more. Don't forget, we're sharing all the full episodes on our YouTube channel as well, which offers that visual element. So if you want to check it out, head over to Mechanical Care Forum on YouTube. Do stay with us through to the end to hear what's coming in future episodes. So here we go. Here is episode 399. Enjoy.
Okay, here we go. 1 second here. So with me today on the Mechanical Care Forum, I'm pleased to welcome Chris Chase and Emily Dabrowski. Guys, I'm really excited. I'll have one question before we start, and I'll let you guys do introductions, but Chris, you mentioned that we had to wear this every day since we're in Austin, and I'm just wondering, you let Emily take it off toward the end of the day?
Yeah.
No, they changed the rules after I got here.
So It's now cowboy boots instead of cowboy hats, Jason.
Okay. All right. Well, I'll set that aside then. So, no, but thanks, guys, for joining the podcast. Thanks for coming back, Emily. Chris, welcome again. It's been a while.
Right, Jason?
Yeah, Chris, tell us a little bit about your professional background, just to touch. You joined me a long time ago, but it's been a while. So just a brief mention on your journey to this point, if you don't mind.
All right. So I graduated way back in 1999 with my master's from St. Louis University and was very blessed. I worked for Dan Kelly as a tech while I was in grad school and spent a lot of times working with a diplomat. So I took my first Part A in spring of 2000, was credentialed by 2002, and have been really blessed. I've had 3 primary jobs in a 23-year career, and they've all been working in a primary Mckenzie environment. I did my diploma training in 2008, moved to Austin after completing in 2009, and pretty quickly joined the mentoring aspect of the diploma program and started officially mentoring as an assistant diploma educator first in 2010, and then became a full-time mentor after I became faculty in 2012. I'm now senior faculty, and I am happy to say I've worked with over 100 people. A number of them are still waiting to take their exams, kind of like somebody on the other end of the microphone right here. But I've officially worked with 100 people that have passed the diploma exam as of earlier this year, which is really exciting. So
Cool.
I live here in Austin, Texas, my wife and 2 kids, and still treat patients 40 hours a week, every week. Sometimes I'm working with you guys, and sometimes I'm doing it just like everybody else. But then I do spend time both mentoring, in addition to the diploma students, some of our fellows. That's all done remotely. And then I spend some of my weekends teaching courses. So
Okay.
I think that's pretty much what keeps me busy here.
Yeah. And of course, we'll throw out Kim Green. Of course, she's your partner in crime there, and wasn't able to join us for today, but that's cool. Emily, you're now through what, 7 weeks plus?
This is the middle of week 8.
Okay.
So we're
awesome.
so close. I can smell the finish.
You can smell the maple syrup from Vermont, right? All right.
Yes.
Yeah. So guys, I'm going to have you guys give a bit of structure. We've heard already, listeners have heard from Tina and Tua in Denmark with Klaus and Annette. And they've heard from Todd and Tim in New Jersey with how it's going with Tim. He's also finishing up about the same time as you are, I think, Emily. So I thought we would just kind of run full circle here. I knew Austin has been a place for a clinical residency for so many diplomats over the years. So we certainly wanted to include. So I'm grateful, Chris, you're able to squeeze us in here. Talk a little bit about the structure, Chris, just of the clinical residency in Austin.
Okay. So, I think you've probably seen this from talking to people from other sites. Each site has a little different culture. Part of that's based on where you're at in the world, and part of that's just based on the needs of the actual clinic. So a little history about the Austin training site is Mark Miller and Scott Herbawi started it over 20 years ago. They were the primary mentors for years. When Mark moved on to his current job in Tallahassee, Michelle Miller and Kim Green kind of replaced him. And then they brought me on, and Scott and I and Kim did the program for years together. When Scott decided to move on into private practice, now Kim and I have been running the program for the last probably 6 or 7 years. So we are a hospital-based clinic. So unfortunately, we still have to follow a lot of hospital-based rules and fill out paperwork that's hospital regulations, in addition to all the Mckenzie paperwork and various things to do. But the way we've designed the program, the one commonality of all the programs is it's 360 clinical hours. But what does that clinical hours detail is we break that up into different sessions. A certain percentage of that time, roughly 5 hours a week, should be dedicated to manual therapy practice. Almost every site handles at least a couple hours of tutorial topics and sessions a week, which involve there's a diploma manual that guides you through all the necessary themes and topics to go through. And then a vast majority of your time will be in clinical reasoning, performing evaluations, performing follow-up visits, discharging patients, and really doing clinical. So a vast majority of those 360 hours in Austin are going to be involved with direct patient care with either Kim or myself in the room, standing outside the room, listening in, watching what's going on, giving you feedback from everything is, are you filling the form out correctly? Are you using the right language? Are you choosing classifications based on MDT principles and logic? To, should we be going faster? Should we be going slower? Should we be considering other classifications? Are we identifying all the risks and barriers to recovery? Are we identifying yellow flag behaviors? And really getting at using the Mckenzie approach at not just a credentialing level, but at the highest diploma level. And really, in my opinion, you can't get that from just reading the books or even attending the classes. You have to have somebody over your shoulder watching you make decisions and really, performing that clinical mentoring / tutoring in a collaborative environment. So as both of you know, we give feedback, both constructive and hopefully always constructive, but sometimes positive and sometimes, why aren't we considering this? But a vast majority of that time will be done in a true clinical environment. Now, that being said, we're also trying to prepare you for 4 verbal diploma exams, which is the ultimate finale point. I don't know if you're going to do a podcast on just what the exam looks like at some point, but maybe you got to take that exam first before you do that. But it really is one of the most stressful but rewarding clinical achievements is if you can pass these exams. There's 4 exams. One's on the lumbar spine, one's on the cervical thoracic, one's on managing extremity patients, and one includes research and other topics, which you're given some guidance for preparing for. So one of the things that Scott really was adamant in being my mentor as a diploma mentor was that we tend to do most of our tutorial topics kind of diploma exam style, where we'll give you a topic to present. We'll ask you questions in usually an oral fashion. Sometimes we do give you some written homework assignments and various things, but we really try to make you perform some clinical reasoning and instruction based on your memory to help you prepare for those diploma exams. So I will say our tutorial topics tend to be a little bit stressful for some. There was a nickname that we go when we do them in the lunchroom most of the time, but it's somehow been nicknamed the woodshed.
That's the first I've heard of it.
Yeah. So, and for some people, it's more painful than others, and for some people, prepare themselves, more than others as well. But so that's kind of what the experience is like. And in Austin, we're generally a busy clinic. We see about 60 to 70% of our patient care is spinal, and about 30% is extremity. We've kind of kept track of that over the years. We did have a couple of doctors move right next door, actually, that do total hips and knee replacements. So we do have to keep them happy, but luckily we have a fabulous physical therapy. I should have mentioned Brian Davis, our physical therapy assistant and athletic trainer, credentialed athletic trainer, I guess, works with us, and he does most of our post-op care in the office. So we do get to learn how to manage a physical therapy assistant using the method as part of your experience when you get to come to Austin as well, which is actually something that I think a lot of people have taken some real positive experiences with. So I think that's pretty much the Austin experience. I mean, you guys have both lived from it from the other side. If I'm missing something, Emily or Jason, you let me know. But a vast majority of your time is truly treating patients, using the system. I think, feedback from dozens, if not literally over 100 people coming through, is we tend to see a lot of challenging patients in Austin. We're the spine and sports medicine clinic. We had 2 new patients today. Both had been referred directly to our clinic because one had therapy someplace else and hadn't gotten better, and the other one's trying to prevent surgery with significant myotomal weakness. And they both have basically said, these guys are the ones that can help you. So for some people, I do think it's a little stressful, like, where are all the easy ankle sprains and various things? And we do get a few of those. We have a couple work comp doctors that love us.
We don't want those, though. That's not why we're paying for them.
Yeah. Well, 1 or 2 a day is okay. So you start doing 5 or 6 of them, it gets a little boring. But we do tend to see a fairly challenging, we are not a pain clinic per se, but with a lot of spinal patients, you do see some yellow flags and some behavioral issues come through the clinic at times. But I wouldn't say we're heavy on it, but I'd say we're really good at addressing it and recognizing those barriers to recovery and integrating those into your plan of care and various things. And I hope you both have seen the experience of, when is mechanical care dominant and when do we need to consider some of the others and medical issues that can, come up and various things.
Yeah.
So.
Mm-hmm.
Yeah, no, that's great. And I will say that I felt like Austin was right in between what I'm hearing about Denmark and what I'm hearing about New Jersey, insofar that Denmark a little slower, fewer cases total overall over the 9 weeks. There's a lot of review, I think, and discussion afterwards, maybe that's a little bit more formal, perhaps, about the patient cases. And then I hear from Todd and Tim how they start at 7 and sometimes go to 7 or 8 on the long days. So it's
Todd has a couple of really long days and a couple of easier days to balance it out, though. So
yeah. So, but I thought the pace was really quite manageable. It was nothing too overwhelming at all. Yeah, you agree, Emily, in terms of enough time to get through the patients, stay on track. So excellent. Well, thanks for going through the structure, Chris, and helping us get an appreciation for that.
I will say, Jason, it is a requirement you finish your 360 hours. And we have had some people finish their 360 hours by the middle of like week 7 and week 8. So it's, the days can get long, although we try not to push people too long and try to, integrate. You got to take a couple of days off over a holiday when you were here, and we try to keep people sane, but there is a little different flavor. I'll just say, like, I had heard from one of our prior sites, it's been done for years, they had gotten slow to the point where you were only seeing a couple patients a day some days and only 15 evaluations total in 9 weeks. And I would say the typical day in Austin is 2 evaluations a day. That means some days there's 3 or maybe even 4, and some days there's 1. But most people evaluate or are involved in about 100 different patients' care in their 9 week. I meant to say that earlier. So I think you will see a wide variety of patient care when you're in most sites, but especially I can speak to the details in Austin. So.
Yeah. Yep. Excellent. Emily, you've walked us through your thoughts coming into the theoretical, midstream and theoretical, post-theoretical. We've seen you kind of, talking you off the ledge, I guess, in both the directions. Not really.
I haven't watched any of those prior podcasts. I'm not going
to. That's right. But give us an idea, coming out of the theoretical and approaching the clinical, what were your hopes, your goals? What were your objectives coming to Austin?
Yeah, I've been thinking of that question. Honestly, I don't have a clear answer. It was more just, I don't know what I don't know. So it's kind of up to these guys to help me figure out what I didn't know before.
Yeah.
And just kind of cleaning up how I approach things, how I evaluate things, what things I don't need to include. So to me, my biggest statement is just, I didn't know what I didn't know. And I'm hoping that now I have filled those gaps.
Yep.
I would assume. So, otherwise, they would tell me if I didn't, is what I've.
So, Jason, I can kind of answer for her just based on her weekly reflections of things like she was looking to gain some efficiency for sure. She was definitely looking to be more clear with some of her classifications and when to go lateral and when she should be using her hands and not be using her hands. And I will say, I've given her this feedback. She has had a lot of the very typical diploma style requests and those kind of gaps in skills. There's just certain things that you start to see that diplomats pick up much faster than your average Mckenzie credentialed therapist. And I think she might not have known what they all were, but based on her questions and where she's looking to improve, they were some of the same things you probably were experiencing, but many of us when going through the diploma program experience.
Yeah, fair. We knew that there wasn't any week 3, like we've heard from Julie, I think, who's a recent diplomat, where she really felt things started to click. And other people said, no, it was on the clinical. You didn't have such a hard transition, Emily, I think, if I remember correctly. Are you
I think I've listened to so many of your podcasts, and I'm not just saying that because you're on this, but I really feel like it's kept me a little more current and like hearing difficult cases being discussed and getting a little more clinical reasoning than I would have had if I was just doing my own thing, punching the clock every day, only having been certified. So I think for that, I've been exposed to some of the thought process I needed. I mean, it was definitely fine-tuned here, but to me, there was never this, whoa, now I get it kind of idea that maybe other people have felt.
Yep. Excellent. So let's talk a little bit about the strategies of how, Chris, you individualize, I think, the residency for every clinician. If you just think about Emily's or mine or some of the recent guys and gals that have come through there, how do you guys individualize it so that it still has the basic structure, you're still hitting all the parameters and the topics that need to be, but you make it specific to the clinician? Yeah,
excellent. Well, so honestly, week 1 is you getting to be comfortable with us and us getting to be comfortable with you. And I tell people at the end of their first Friday, how did that first week go? And no judgments were made because it's stressful for all. And then by that second to third week is where you really start to see some personality develop and we really start to look at individualizing. And you're right. I will say one thing I didn't realize is coming as a mentor, various gaps and deficiencies and strengths. And some of it's very academic. Like, no offense, Jason, you hadn't taken the classes in recent. So like the other category was something you weren't as quite up to speed with, somebody that's taken the courses in the last few years where the other has been much more, part of the curriculum. So we spent probably a little bit more time going through those just academic areas. And that has actually been very true of anybody that's been credentialed for more than about 10 years coming through diploma, I would say. But academic stuff's easy in a lot of ways. I mean, some people really have a deficiency in the extremities because they don't treat them in their home clinic. And so that becomes a little bit more challenging to really give them enough, cases and feedback and challenges. And you can't always guarantee that you'll see, something in the other category or a cool contractile dysfunction and only a 9-week gap or a cool A&R. I mean, you're going to see a few unique things in 9 weeks, but I can't promise you see them all. So sometimes we have to do a little bit of creative role playing or something if somebody really exhibits one of those. But I would say the real challenge becomes not just the academic, but more the personality issues. Some people come in and are just naturally great communicators. And that's actually much easier if they have knowledge gaps than somebody that's got great book knowledge and they've read the research, but communication is not a natural skill. And so you'd be surprised at how different a clinical experience might look for somebody that has trouble getting buy-in on their education and their exercises, getting compliance with their programs. And so there is I probably can't even come up with all the different challenges I've seen over 10 plus years doing this at addressing different things. But I will say, I try not to make too many judgments early on. And then as I get to see your personality develop is when we start to become a little bit more critical about why were you doing that and what's the reason. And you'll often say, I don't look for yes, no questions, just like with our patients, very open-ended and what's in your mind and what's in your thought. And if it makes good sound reason, we talk about why that is. And if it doesn't, we'll challenge you about what could go different and why to do it. So, but I will admit, I'm going to throw one more common piece out there. Is a lot of people have come to Austin over the years internationally as well, where English is a second language. And now you can throw on the added, I've just gotten my English TOEFL score up to the point where I can do the program, but I still don't have much medical background. Or they speak pretty good English, but they don't speak very good Texan, and they can't understand what the patients are saying and various things. Luckily, your Tennessee translated really well to Texan, Jason. So
everybody right in
really well. Sometimes
it was okay.
Yeah, Vermont's been pretty good, but sometimes the New Yorkers, they know right away it's a Yankee in the room.
But way different than New York. Vermont and New York.
But there is sometimes very cultural differences as well that need to be addressed. And that may be not as much Mckenzie as just more physical therapy kind of concepts, but it all becomes part of the diploma experience in looking at how do we mentor, how do we guide. And like I said, it's actually much easier to guide somebody with academic gaps than it is from, say, communication gaps or, somebody that really does not have strong communication skills gets a very different clinical experience than somebody that's already been doing this for a while, that already has strong interpersonal, communication skills.
Yeah, no, that's a great point. Yep. I think it was my cowboy hat that made me connect with everybody down there so well. So,
yeah. So aren't you glad I made you wear it all 9 weeks? So.
That's right. Yeah. All right. Let's talk about a couple of patients. Emily, I asked you to think about this before. And again, just divulge as much as you want. You can kind of hint around it so that Chris knows who you're talking about. But just give us a picture of kind of those moments that we, I've still got several patients in my mind that I was seeing, and it was like, that was very helpful, or I needed that, or, ooh, boy, did I miss that mark. And going through that process, I'll not forget about the deformity in cervical spine again, because I know that I've got to, handle that differently than someone without the deformity. So are there patients in your mind that just kind of were a good representation of moments where you just had a little clarity and just describe that?
Yeah, these are more patients I saw with Kim, so Chris wasn't even there.
Okay, yeah.
But I feel like it was like my first week. So there was one where it was a cervical derangement, and she worsened with sagittal, so we needed to go lateral. And so Kim had asked me, should we go lateral flexion or rotation? And I forget which one I said, but it wasn't the one that Kim wanted to do. So she was like, I can see the reasoning. However, so what I will say about these guys is they're so great in how they give you criticism, and none of it feels like criticizing, to be honest. I'm not sure what you felt, probably not much different, but very positive. And it never makes you feel like, oh, I was wrong.
Yeah.
And the patient doesn't feel that way either. The patient feels like we're all part of the same collaborative discussion.
Which that is a challenge, to be honest, to make sure a third person in the room doesn't feel awkward with the patients. That's a real skill that we work hard at. So
so that was one case where, and believe it or not, she actually ended up responding to what I wanted to do, which was,
of course,
I was proud of that. Regardless, in the moment,
what does Kim know? Yeah.
So I was 0 for 1 there. And then there was another one where, like a radiculopathy, but it was an older thing, and that had a recent recurrence. That whereas I felt as though he did have obstruction with rising in his history, there wasn't enough from Kim's standpoint to really feel like we shouldn't explore flexion first. So another one of those, like, where should we start? And I'm like, I think we should start with extension. And she went, yeah, I see how we could do that. However, I was like, darn, I'm 0 for 2.
Yeah.
So just those little things, just seeing more like where to start exams, the reasoning behind that, I think has definitely been kind of polished with my experience here.
Yeah, Chris, talk about that decision to look provocative or look exploratory and deflection or reductive. It's a common thing I'm sure you guys are handling with most candidates that come through there.
We kind of break it up into the first 3 weeks. We'd really focus on taking a good history and learning to fill out the form. The middle 3 weeks, we start to really analyze the choices we're making with classification and forced directions and progressions. And the last 3 weeks are really emphasized in cleaning it all up, putting it together, strong education, getting buy-in. So those middle 3 weeks, we really do start challenging you. Why did you choose that first? And when would you go lateral? And so, it's a complicated question we could have an hour-long discussion on, but I will just say this. If you still have a big question that needs to be answered, you shouldn't treat. Don't make any assumptions. You should try to pick whatever you're going to learn from, which in many cases is flexion or something that could be provocative. If you have a strong sense of, I have my classification based on my initial baselines and history, then it's okay to begin to treatment, but know that you're still always on that first visit, critically analyzing, are the responses making sense? And am I getting a response that I'm comfortable continuing to progress with this force? And I definitely think, one thing along that line to take another level is, a lot of people think in the Mckenzie Institute that we don't really want to use hands-on very much, and very few people need. And I don't know, by the time you're a diplomat, I don't actually use my hands to manage many patients anymore, it seems like, but I still use them a whole lot during the evaluative process. I remember you mentioned that particularly, and I'm not sure if you've noticed that, Emily, how quickly I use my hands for overpressure to learn. So it's like, it's another tool to assess our patients when I don't have a clear answer, because I want to know if I should be going lateral on day one. And I want to know if we should be avoiding flexion or versus maybe it sounds like that Kim was worried about whether or not that radiculopathy was really an MUR at this point versus a derangement. And if there's not a clear answer, and I'll end with saying, don't be afraid to make people worse. Sometimes when you can make somebody worse, you can also make them better. If you're worried about ever making somebody worse and you're always like living in fear of moving somebody, you end up just stagnant and status quo. And then the patients get frustrated and you get frustrated. So there's not a straightforward answer. Hopefully that got to your question. But I mean, I think ultimately, if you have good knowledge base, then start to progress with management. And if you have questions that need to be answered, choose the movement or the testing strategy that's going to answer the critical questions. And I'd always say, if you're not sure what body part it is, you better start doing examination to rule in, is this shoulder really a neck? Is this SI truly an SI, or could it be a back? If you have a good, strong suspicion of what body location it is, then you start to choose your classification. And if it's it could be a derangement, but there sounds like there's a whole lot of yellow flags and maybe more chronic pain syndrome style stuff. Maybe that's a good patient to do something provocative to see if you can change obstruction or change baselines. And then if you have a good idea about classification, then you know what, let's choose an end range direction to learn. Maybe it'll expose lateral, and then ultimately figure out what the right force should be. And so you can kind of structure, and I know you guys both know what I'm referring to. It's tutorial week 2, where we really get into how do you make decisions. And if you can't answer a single question, don't start choosing an exercise without a reason to do it.
Yeah. Good. Thanks for clarifying that. Emily, you remarked to me in one of our get-togethers with our cohort, just the fact that you're using combined movements. You're using a little lateral with some sagittal. That wasn't something you were doing before. Is one of your takeaways that you mentioned. Do you have a patient in mind? You kind of clarify how you've seen it happen and kind of how you see the benefit of it.
I feel like there's a lot, but even just when people, like cervical spine derangement example, say they peripheralized with sagittal and you had to go into lateral flexion, they might get to a point where they can tolerate sagittal, but they're kind of on the cusp of, but they really need 5 lateral flexions first before they can do 10 sagittals successfully. So just that kind of stuff. I think I've seen it a fair amount. And again, I came into this thinking that was sacrilegious, that no one direction at a time. Because again, I don't work with diplomats. There's nobody around me that does this. And I think when they teach, part A, part B, you kind of have to get it down well. So I think you shouldn't be messing with too much of combine this with this. You just need to understand, is it sagittal or lateral, So coming into this, I didn't think that was allowed, but now there's so much value behind like really individualizing the approach with derangements for people, because no two are created equal.
Yeah. I can think of a couple of patients both in the neck and spine where Emily and I have had to transition from lateral, and it's not always a smooth transition where you go directly from lateral to sagittal. Sometimes you combine two within the motion. Sometimes you always 10 side glides against the wall before you ever do your press ups. And there's kind of like, I talk about a sliding scale about how much lateral you need to do as you wean off it, as you go back, return to the sagittal plane. And you've actually seen a couple of really challenging laterals to get them back to the sagittal plane, where we've instigated all sorts of different strategies. I would say that's one of those, now I know what an anterior flexion responding derangement looks like. Now I know how to transition from lateral, because I do think people think it's only just one movement. And then generally on the first visit, we do want to send people away with only one movement. But there are times you're doing a series of a couple of motions to reduce a really challenging derangement. And even the patient that every morning they check a motion, and if they're stiff, then they got to do their side glides till it's clear. And some days they do more than others. And teaching not just it's a black and white X and Y, but even educating your patient that you got to know when to do more or less as part of using the system at its highest level.
Yeah, it seems like we were commenting there, educating the patients, hey, we're trying to elicit a response. And when you see this response, you know that you're ready to move on to the other or whatever. So yeah, that educational piece is pretty critical. Thanks for clarifying that. So we talked a good bit about a few patients that are the technical MDT delivery, assessment and management type of patients. What about those challenging ones where you're just trying to connect with the patient to build a bond, or you're just trying to overcome some mistaken beliefs or some fear in a patient? Have you worked on that? Have you seen some patients, Emily, where you thought, okay, I can see how I need to use some resources more, or just spend a little more time on convincing, or let the motion prove to the patient that they're not going to just re-obstruct or that type of thing? Any patient come to mind with yellow flag kind of beliefs and attitudes?
Yeah, I mean, I had one this morning that Kim and I evaluated a few weeks ago, and it was like a trauma at work. It seemed like a derangement. She obstructed when she raised her arm, and just transitional pains that looked like a thoracic derangement, right? But day one, we were doing some reductive maneuvers, and everything just got increase worse, no change in mechanics. Like not your typical, like, oh yeah, you should be obstructed that direction, just kind of a weird, like all over the place. Her history, she had 2 prior back injuries with her current job. So there was some of that contextual blue flag stuff going around. And initially my thought probably was, let's see if there's a derangement. Maybe we just have to go slower, and maybe don't go as far and as fast, and let's build alliance to reduce the derangement. But Kim and Chris are both like, it's chronic pain and there's a resolving trauma and yellow flags. And sure enough, like once we just kind of backed off and just have been working on just, education, positivity, functional training. She actually this morning was like, can we up the ante a little bit today? Can we do more? I was like, sure. But if you get worse, it's your fault, So she's, I think, come a long way in a couple of weeks. But I might have eventually figured that out on my own, or she may have just quit the system before I got that far, But just kind of switching gears and going to that approach early on, I think has really, really kept it successful without losing her.
Yeah, I was going to just ask, is that the difference where as a person progresses through this process, the ability to define that, recognize that, and move on is quicker or more efficient?
I think that one difference is that you'll see. I mean, I have had some people that come in with that gift of connecting and convincing people they sometimes are better than they actually are. It's kind of the flip side. And I'm like, yeah, but they're not really changing. You're just talking them into being better. They say they're better because they like you, but they still can't bend over and pick up their kids, or they still aren't working yet, or, returning to their sport. But I will say Emily's had a collection of some pretty strong blue flag or fearful behaviors with returning to sport and various things, where we have pretty quickly into the plan integrated, some fear reducing strategies while we're reducing a derangement or while we're addressing, like that particular patient is definitely probably more chronic pain, but we've actually had some derangements with some pretty significant barriers where we're probably integrating other things earlier. And I will say maybe that is another difference between a diplomat, is their willingness to integrate addressing additional things as they go through the reductive process with a derangement, or as they're remodeling a contractile dysfunction, letting them explore other activities. We're probably a little less, you can't do anything, and more inclined to treat the big picture and look at ways to get them, even if it's not speeding up the recovery, just get them back to life in some regards as they still go through the system. But, really addressing true yellow flags and knowing how important they are, that is a really tough thing to teach in a course, and much easier to address when you're treating patients together. even like if we just had a 2-day, and I think the Institute will pretty shortly have a 2-day chronic pain intensive course on how to manage people where this is their primary driver, it's still going to be hard to do that through role playing as opposed to actually doing it with people with real emotions, real fears, real belief systems in play, and what strategies work. And there's all sorts of different strategies you're going to have to learn to address people with different beliefs and systems. So, but yeah.
Yep. Yep.
And I don't care what environment you work on, that's part of the experience of people in pain. I actually got a chance to work with somebody that had done their diploma training over at a different site in Europe. And, he looked and he said, your patients, there's a few yellow flags, but man, you got really good mechanical patients compared to like some of the yellow flags and real chronic behaviors by the time they would qualify for therapy in their system. And, it's like he spent a lot of time in his clinical training addressing, just getting people willing to even do something before you could reduce it or whatever. And so there is differences depending. I know a number of Mckenzie trained clinicians have gone to work in kind of chronic pain clinics and various things. And then when you're doing it all day long, the system still works wonderful. You might have to be a little bit more creative and address things a little bit differently or quite a bit differently, because when we're focusing on, positivity and education and teaching, empowering, controlling your symptoms through exercise and the right education, it's what, the research supports works. And it's what's the core foundation of all MDT treatments, no matter what the classification is.
Yeah. Yeah. Emily and I and our cohort, Chris, had specific goals and intentions and hopes as to why we wanted to go through this program. For those listening out there who are kind of on the fence and they're thinking, maybe I want to, you got to almost do a diploma with Dan Kelly. And by the way, there's a lot of clinicians out there and listeners who don't even know who Dan Kelly is. So maybe you remark quickly as to who he is and why that was such a valuable experience. But who is this program for, and who do you see really sees the value in it and is appreciative and kind of glad they went through it?
All right, that's a great question. So let me first be respectful and mention Dan was one of the original Kaiser Fellows. He and Kathy Hoyt, Hugh Murray brought Robin over to teach a course back in the late 70s, early 80s, and were some of the founding founders of the Mckenzie Institute. Dan was the original credentialing exam and diploma exam writer. He's contributed to the original blue textbooks and was the chairman of the board for years. So Dan's one of the original gangster of the Mckenzie Institute. And I got to work with him every day for years. And Dan, he taught me so much, but he also let me make mistakes and challenged me. And he did kind of give me a mini or a full diploma experience in a lot of ways. That's very true, Jason. But so here's who it's for. And I've thought about this a lot over the years. People come for different reasons. Some people come in like, I want to be faculty. That's the only reason they're doing it, to check a box off because they think they want to teach this. Okay. I wouldn't say it's necessarily the best reason, and it doesn't always end well if that's the primary reason you want to be doing this, but it's definitely something I've heard. I've had like maybe 3 or 4 people out of over 100 say, I really want to be able to understand the system better, to research it better. And those of you listening that love to write and research, we need more of you guys out there. And I definitely have seen a number of my graduates, gone on and written papers and co-authored some really great stuff, which is awesome. But probably the most often and probably the most meaningful for the person going through the program is, I want to be better for my patients, or I want to be a better mentor. I'm kind of the spine guy at my clinic, and I think I'm doing a pretty good job, but could I be doing this better? And could I be even a better mentor for my colleagues and coworkers? And I really think probably the ideal diploma candidate is that person that's got a few years experience, that's getting pretty good at what they do. And they don't just want to be even better for their patients, but they really are looking to be a leader among their profession, whether it's PT, chiropractic, whatever. Now, that's not to say that if you want to research better, doing the diploma program, you're going to read a lot of articles, you're going to get challenged in a very meaningful way, and it will help you, write. Although I don't know that we really give you guidance on how to write better, but we definitely get you prepared for the types of things that need to be studied. But the 2 things I hear is I want to be a better mentor to my colleagues, people that are involved with study groups and various things. And really, truthfully, I still hear it. I want my patients to get better as good as the people that I've seen on these courses and various things. And people that have that as their ultimate reason for doing it usually do very well.
Mm-hmm. Yeah, excellent. Thanks for summarizing that. That's great. any last words of wisdom, Emily, as we transition before you finish up that piece, and then you
be careful what you say. You haven't had your final remarks or grades yet, so no.
I told you that.
Yeah.
Yeah, I mean, my biggest thing is just the overall, like you and I have talked about. If you want to do this, you can do this. I survived theoretical while working full time and 3 kids under 6. I'm here and I'm pretty sure my family's still alive. I've got 3 back home, right? I mean, there's never really a best time. I put this off because I was like, well, maybe when they're older, maybe this. Like, there's never going to be the best time to do this. Do what's right for you. But if you're interested in doing this, just bite the bullet and just do it. I'm excited that I'm doing it now, and I still have a lot of years left in my career. Versus if I think there's some other people I mentioned, well, I waited till my kids were older, and now I've got this many years behind me. But I was like, if I'm going to be a PT and try to make a difference in my community, I want to be as good as I can now and not just wait to be better 10 years later. So I mean, yeah, it's expensive, but, I think you definitely get your money's worth. And there's a lot of reading, but it's all great. It's current evidence-based stuff that's even outside the Mckenzie world, which I think is fantastic. We're not just tunnel vision, only MDT literature that I just fear that some people might think that we are, but it's a lot of great current evidence across the board. So my biggest thing is just, if you want to do it, just find a way to make it happen. It's only a year or 2 commitment, and it's totally worth it.
Yeah. Excellent. All right. Well, I appreciate you guys taking time after a busy day and squeezing this in. We appreciate, Chris, you joining us to be able to kind of clarify some on the Austin site. And Emily, we will see you down the road. And I'm still a little bit, peeved that you're not having to wear a cowboy hat around, but that's all right. I'll get over it.
It's all good.
No, I appreciate you guys joining me. Thanks for joining the podcast.
Thank you.
Jason, thank you.
Okay, so there you go with episode 399. More insights into how Emily and I were feeling and how we're seeing our clinical skills and reasoning develop through this phase. And from Chris's perspective, how he facilitates learning. There's no doubt the uprooting from our homes and practice settings is no small feat, but hopefully you can appreciate and hear that it's attainable, even for someone like Emily with small children and a busy life. Stay tuned for a look at a group of candidates as we prepare for the final exam, the final phase of this diploma program. That coming up next episode. And don't forget to subscribe to my email updates to be notified of new episodes. You can do so by clicking on the sign-up bar at the top of my website. Subscribe to the podcast on your favorite podcast player and follow me on my social media channels, as we'll be notifying you when episodes come out. If you're hearing the audio version, do know that we are releasing the video version of the podcast on our YouTube channel as well. Again, we want to thank today's sponsor, the Mckenzie Institute International, providing worldwide training and support to clinicians in the principles and practice of the Mckenzie method for the management of patients with spinal and extremity disorders. The Mckenzie Institute Diploma Program provides the highest level of MDT training. It enables clinicians to acquire an in-depth understanding of the Mckenzie method and become experts in its effective use in guiding their patients to achieve their personal goals. If you have an interest in learning more about the diploma program, check it out at mckenzieinstitute.org. And if you've heard enough and you're ready, you can apply to enroll in this program through mckenzieinstitute.org each year before October 31st. By the way, if you're wishing you had more interaction with skilled and like-minded clinicians and researchers, we're continuing to plug away here at the Mechanical Care Forum with new cases within Case Conversations, our patient case discussion resource, and with new scientific studies within Inside the Science, our peer-reviewed summary and discussion resource. Regarding Case Conversations, currently we've released a couple of cases where the clinician discovered an unusual directional preference loading strategy. And within our research resource, Inside the Science, we've shared a couple of super relevant studies on using mechanical diagnosis and therapy with patients qualifying for a spinal manipulation clinical prediction rule, and a case series of headache patients who are managed with repeated end range movements versus conventional management. These resources, Case Conversations and Inside the Science, are intended to provide some virtual mentoring for you and help keep you moving forward in your professional development. You can check these out at mechanicalcareforum.com. All right, I wish you a great week with your patients this week. Whether your drive to pursue something like the diploma program is because you want to publish research, or teach, or simply climb a ladder in your organization, do it for the right reason, to be a better clinician. And join us right back here next episode for more of Season 13 and more of sharing experience for improved patient care.